Hello and welcome to this 4-part educational series titled Hot Topics in COPD from Disease Phenotypes to Targeted Therapies. Each episode in the series will be dedicated to one of the following topics: the role of type 2 inflammation in COPD pathophysiology, current evidence for the use of biologic therapies in COPD, comprehensive evaluation of the disease and patient symptoms, and lastly, evolving treatment algorithms for COPD. I am Dr. Surya Bhatt. Thanks for joining me again, and let's get started. Exacerbations are a major component of COPD, and they are a major cause of respiratory morbidity as well as mortality, and they have significant consequences on the life course of COPD. They are associated with loss of lung function, both in the short term, where it can take up to 4 to 5 weeks for patients to regain their lung function back to baseline, and oftentimes they do not return to baseline, and exacerbations can be associated with significant long-term decline in lung function. And the more frequent the exacerbations are, the lung function decline can be significantly accelerated. Exacerbations can also result in significant loss of exercise capacity, which again can be progressive. It's also associated with risk of serious cardiovascular events. An exacerbation can increase the risk of stroke and acute coronary events 3 to 5-fold in the peri-exacerbation period. And oftentimes, some of these cardiovascular events can themselves be precipitants of acute exacerbations. Exacerbations that are severe enough to result in hospitalizations seem to be a sentinel event in the life course of COPD. The mortality associated with an acute exacerbation resulting in hospitalization can be up to 4 to 5% during the hospitalization itself, and about 25% of patients die within 1 year of hospitalization, and up to 50% of patients die within 4 years of hospitalization for an acute exacerbation. And the COPD-related healthcare costs, about 70 to 90% of them are attributable to COPD-related hospitalization. Repeated exacerbations are associated with significant lung function decline in health status, as well as poor quality of life. So it's very important that we evaluate patients for exacerbations when we see them in the clinic. And the best predictor of an exacerbation is a history of previous exacerbations. So the more frequent the exacerbations in the past, the more frequent exacerbations you can expect in the future. But one of the issues with exacerbations is the lack of appreciation of exacerbations by patients. And it's also related to the way we define it. So we define an exacerbation as increased shortness of breath, increased sputum volume, and increased sputum purulence compared to baseline, which often is not perceived by patients till it's quite late. So a significant proportion of exacerbations are not reported by the patients to clinicians. In fact, some of the milder exacerbations, which are not necessarily associated with a change in treatment, about 50% of them are not reported to clinicians. So it's very important to have a low index of suspicion for frequent exacerbations and ask patients, are they going through some of these events? And these exacerbations are associated with significant consequences: increased airway inflammation, both in the short term and the long term, and increased air trapping, which contributes significantly to their shortness of breath. So when you see a person with a recent exacerbation or frequent exacerbations, there are several factors that we need to consider when determining the need for treatment adjustment. First, review what they're on already. Are they on controller treatments in the form of LAMA, LABA, or ICS, depending on the frequency of exacerbations? Whatever inhaler they're on, there's almost about 20 types of different inhalers or more than that. So it's very important to have them demonstrate the inhaler used to you and make sure that their inhaler technique is correct. And in the case of any critical errors in the inhaler use, then correct the inhalation maneuvers and demonstrate it to them. And it's important to demonstrate this periodically every 6 to 12 months, because studies indicate that 1 year after somebody is taught how to use an inhaler, almost 50 to 60% of patients make critical errors and forget how to use the inhaler correctly. Make sure that you ascertain their symptom burden and their exacerbation history at each visit proactively. Make sure you ask them questions about multimorbidity, for example, cardiac disease, anxiety, depression, all of which can play a role into exacerbation frequency. And then also assess the severity of airflow obstruction. Although we don't directly use FEV1 for treatment decisions, it can make an impact in the form of referral for future therapies if it's bad enough. Also, if you periodically, every 1 to 2 years, measure lung function, you can also make adjustments for treatment depending on how quickly the lung function is declining. And then for exacerbations, in addition to the history of exacerbations, there are certain other things that you can use as pointers. for predicting high risk of future exacerbations. One such is the increasing recognition of type 2 inflammation, which is indicated by elevated blood eosinophil counts. Usually at around 100 to 150, the risk of exacerbation starts going up, and around 300, the exacerbation frequency is markedly higher than in those who do not have an elevated blood eosinophil count. And it's not just for predicting exacerbations, but eosinophils can also be used for predicting the magnitude of effect or response to inhaled corticosteroids in preventing future exacerbations. And some of this is reflected in the GOLD document, which indicates that between 100 to 300, you should certainly consider inhaled corticosteroids for the appropriate patient, and above 300, it's almost certainly indicated in those who are frequently exacerbating. Also, make sure to comprehensively evaluate patients during their clinic visit. Make sure to check a 6-minute walk distance to check their functional capacity. Evaluate their symptoms semi-quantitatively or semi-objectively by administering an MMRC questionnaire, where 2 or more for the MMRC dyspnea score is considered clinically significant, and also administer the COPD assessment test, where you can assess their symptom burden and the impact of COPD on their disease. The score ranges from 0 to 40, 0 to 9 being considered low impact, 10 to 20 being considered medium impact, and 20 to 40 being considered high impact. The latest 2025 GOLD report includes several updates to the strategies that we can employ for treating patients with frequent exacerbations with the goal of reducing their exacerbation frequency. Some of this has been in place for quite a while. So in patients undergoing frequent exacerbations, they need some form of controller therapy. So the current recommendation is to use a combination of LAMA and LABA for decreasing exacerbation frequency. In those who have an elevated eosinophil count between 100 to 300, consider the use of inhaled corticosteroids. And certainly if they're on LAMA and LABA and continue to exacerbate, then definitely add an ICS. Or in those with eosinophil counts greater than 300, we can go straight to LAMA, LABA, and ICS. And the new GOLD report also indicates that there is some retrospective post hoc data suggesting that the use of LAMA, LABA, and ICS in those who frequently exacerbate can also decrease mortality. And this is from data from the ETHOS study and the IMPACT study, both of which showed a significant decrease in mortality in frequent exacerbators who were on triple therapy. There are also several anti-inflammatory medications that are recommended in the GOLD report. One is roflumilast, which is a PDE3 inhibitor. And the new addition to this armamentarium is the approval of dupilumab recently, which is an anti-IL-4, anti-IL-13 monoclonal antibody. And this is now recommended in the GOLD report for use in those with frequent exacerbations and high eosinophil counts greater than 300. Anti-infective therapy is also recommended in the form of preventative therapies in the form of vaccines and long-term macrolides in the form of either azithromycin or erythromycin. And it should be noted that these macrolides also have anti-inflammatory activity. There is also mention of mucoregulators in the form of N-acetylcysteine, carbocysteine, and erdostine, all of which have been shown to decrease exacerbation frequency. There is also mention of several non-pharmacologic interventions for the decrease of exacerbation frequency. One is smoking cessation, and the other is pulmonary rehabilitation, both of which have been shown to decrease mortality, mostly in retrospective studies. There is also recommendation for consideration for lung volume reduction in the appropriate patient, vitamin D therapy, and then shielding measures such as mask wearing and minimizing social contact, as well as frequent hand washing, which we've all learned during the COVID pandemic that can reduce exacerbation frequency significantly. So what are some of the non-pharmacologic treatments that we can employ for decreasing exacerbation frequency as well as improving symptom burden? Perhaps the most effective therapy that's non-pharmacologic and is perhaps arguably more effective than some of the pharmacologic therapies is pulmonary rehabilitation. This is a series of exercise interventions, which is about 2 to 3 sessions a week, and includes aerobics, strength training, as well as breathing exercises. And there are some post hoc studies or retrospective studies suggesting that there is decreased mortality associated with pulmonary rehabilitation, especially when employed post-hospital discharge. Several other self-management strategies are also included in the GOLD report, and these include increasing and maintaining physical activity, improving nutrition, making sure to get adequate sleep, and then the use of written action plans for avoiding exacerbation triggers, as well as monitoring symptoms and then treating exacerbations appropriately and in a timely fashion. And in those who have exercise-related or resting hypoxemia, oxygen therapy is indicated. Smoking cessation is an important intervention in the management of COPD, and there is evidence to support reduced mortality in those who quit smoking. Approximately 40% of patients with COPD continue to smoke, and the GOLD report suggests using the 5 A's for aiding smoking cessation. And this includes ask, advise, assess, assist, and arrange. Ask meaning ask the patients if they are interested in quitting smoking. Advise them to quit smoking. There is data to suggest that if a physician advises to quit smoking, there's almost a double chance of the patients actually quitting smoking. Assess their interest in quitting smoking, and then assist them by providing pharmacologic and behavioral counseling. These interventions have been shown to increase the quit rate by almost 50 to 70%. And then arrange for a follow-up. So don't just recommend quitting smoking and not have a follow-up. It is shown that if you follow up and check in on them again, the chances of quitting smoking significantly improve. Tobacco dependence is a chronic condition which is not a one-time fix, and it requires repeated treatment and repeated interventions and counseling till permanent abstinence is achieved. There are some effective therapies for tobacco dependence, and all of the COPD patients should be offered these treatments. There are some pharmacotherapies in the form of varenicline, bupropion, nicotine gum and patch, and nicotine inhalers, and also, controversially, the use of e-cigarettes, which may be a trade-off in the form of quitting tobacco, in the form of cigarette smoking, and then taking on e-cigarettes. So there is some controversy about this, but all the other pharmacologic therapies have been shown to be associated with improved quit rates. And it's important to be persistent. Some patients can take up to 30 attempts to quit smoking. So the more times they try to quit, the more likely they are to eventually succeed. Several vaccines are also recommended in the updated 2025 GOLD recommendations for the prevention of acute exacerbations. It is recommended that people with COPD should receive all the recommended vaccines in line with the relevant local guidelines. But in summary, it's recommended that patients get a yearly influenza vaccination. They should also get COVID vaccines based on WHO and CDC updated recommendations. And they should get at least one dose of the 21-valent pneumococcal conjugate vaccine, or the PCV21, or the PCV20, as recommended by the CDC. And pneumococcal vaccine has been shown to decrease exacerbation frequency as well as pneumococcal community-acquired pneumonia. RSV, or respiratory syncytial virus vaccination, is recommended for COPD patients greater than 60 years or more. The tetanus, diphtheria, and pertussis vaccine is recommended to protect against whooping cough for people with COPD that were not vaccinated in adolescents. And then finally, the zoster vaccine is recommended to protect against shingles for people with COPD aged more than 50 years. So in summary, exacerbation should not be considered the normal course of COPD. Make sure to ask patients proactively if they've had events that are suspicious or concerning for exacerbations. Alleviation of symptoms and prevention of exacerbations are key objectives in both the short-term and long-term treatment of COPD, given their short-term impact on respiratory morbidity and their long-term impact on lung function decline as well as mortality. And then there are pharmacologic and non-pharmacologic management strategies which can significantly decrease the risk of exacerbations. So we should constantly be reviewing what patients' treatments are on and adjusting as appropriate. Thank you for joining me for this Hot Topics program. You can view other episodes from this series on the landing page. For additional CME opportunities, clinical resources, and links to patient education materials, please visit us at www.exchangecme.com. Lastly, please remember to take the post-test and fill out the CME evaluation to receive your credit.